Check, check. Perfect. Can you guys hear me? All right. Thumbs up, thumbs down, thumbs up. Okay, perfect. Come on in, guys. Thank you all for coming. I am going to try and get us started properly on time. My name is Will Den, and my co-moderator here, Matt Leisler, is going to be the better-looking gentleman to my left here, and I'm going to actually scroll to that slide real quick. This is session 13B. We're talking about point-counterpoint, something that I'm very passionate about, especially since there are a lot of things I don't know about these topics. And so hopefully these experts that we have coming up can help guide us through them. And so we've got an incredible panel for you guys today. Hopefully this is something that you guys will be interested in, even moving forward past this annual meeting. Our sports hernia talk with Gary Ho and Kate Lamont. Hopefully you guys learned a little bit something, because I definitely did. Just want to make sure we have those slides up. I would appreciate that. So the next topic is going to be sports hernia, and I might get corrected by our colleague, Dr. Ho. It might be more athletic groin pain, but I'll let him talk more about that along with Dr. Lamont. And so regardless, Dr. Gary Ho is a fellow of AMSSM, ACSM, and AAFP, holds a number of academic appointments, and is board certified with the CAQ in sports medicine, as well as additional credentialing in MSK ultrasound, POC ultrasound, and management of concussions in TBI. He's been on a bunch of committees regarding sports medicine certification, ultrasound certification, and teaches internationally. He's a team physician for George Mason, as well as a sports medicine physician at Ortho Virginia in the Washington, D.C. metro area. And his counterpart, Dr. Kate Lamont, is a fellow of the American College of Surgeons, having trained in general surgery at the University of Virginia and fellowship at Johns Hopkins in minimally invasive and bariatric surgery. She's the medical director for Johns Hopkins Center for Bariatric Surgery at Sibley, and is an assistant professor of surgery where she practices general surgery and advanced laparoscopic surgery. So we're very, very fortunate to have this pair speak about this very, very confusing topic. I know what it is for me. And so please give them a warm welcome. Thank you.
Thanks a lot, Will. Got a lot to cover. It's great to see everybody, but we'll just go ahead and dive right in. I have no relevant financial disclosures. So when I was first asked to give this talk on sports hernia, I asked for some clarification. I was wondering if this was sports hernia referring to hernia and pre-hernia conditions that we sometimes see in athletes, or was this the historical and colloquial use of the term to refer to chronic groin pain that we see in athletes recalcitrant to more traditional rehabilitation approaches in general. I was advised it was the latter. So with that, I'd like to provide some opening thoughts. Going to review some terminology and some classification for refractory athletic groin injuries and pain, highlighting the non-operative management approaches. I'll provide some rationale for some of those approaches and hopefully segue to a counterpoint from my colleague here, Dr. Lamont, to provide the surgical side perspective of things, and then a fruitful discussion to follow. So sports hernia, the term, has been a term that was used historically to refer to athletic groin pain. And over time, it become to be used by both the lay public as well as clinical providers to refer to chronic groin pain in athletes recalcitrant to typical traditional rehabilitative approaches. Unfortunately, it wasn't the only term that was used in that manner. As you can see on the slide, more than several other terms have also been used, some of which alluded to a particular pathology like sports hernia, and others which were more vague and general. Needless to say, regardless, when you have this many terms referring to the same thing, but all with different nomenclature referring to different things, it gets very confusing and misleading at times. It made it very difficult to communicate when it came to taking care of these patients clinically, but also made it difficult to define the problem for study as we desperately tried to find a paradigm to address these problems and hopefully get the best patient outcomes possible. Add to that differential diagnosis for chronic groin pain in athletes is fairly wide. And so here we have a situation where you have a large number of different pathologic entities with overlapping clinical features, both in history and physical exam. However, each of these entities with its own optimal management approaches, which can vary very widely between them. So defining this problem has traditionally become very difficult, and historically, it was a difficult problem to even talk about. Add to that, in addition to the variation in terminology and nomenclature, as well as that rather huge differential diagnosis with similar overlapping clinical features that can mimic each other, we're looking at an area with fairly complicated anatomy, complex biomechanics, and the pathophysiology at times can be kind of confusing. And this lack of consensus made it very difficult. Fast forward to 2015, and that was the year we saw the publication of the Doha Consensus Statement that came out of a consensus meeting in Doha, Qatar, looking at chronic groin pain in athletes. And this gave us a way forward in order to organize our thoughts and communicate on an agreed upon set of terminology. And in 2024, this remains the current best framework through which to address these problems. And several things came out of this Doha Consensus Statement that was very particularly valuable. I think one was highlighting and calling out the confusion that can occur when you use terms that allude to a particular pathology. They recommended a movement away from terms that suggested a certain problem when talking about the full umbrella of chronic groin pain in athletes. I prefer the term athletic pubalgia. They suggested just plain groin pain in athletes. However, since that time, sports hernia has remained colloquially a favorable term used by the general public and in clinicians. So my recommendation is, if somebody comes up talking about sports hernia, is to ask for clarification. Are we talking about hernia / pre-hernia conditions, which I look forward to hearing more about, or are we talking about just groin pain in athletes, and really the more historical and colloquial use of that term. The other thing that came out of the Doha Consensus Statement was a very useful clinically based classification system that subdivided and attempted to make that huge differential diagnosis a lot more digestible and approachable. What they presented was a classification system based on clinical features, both the history and physical exam, and subdivided that large differential diagnosis into 6 categories as illustrated here on this diagram. These included adductor-related groin pain, iliopsoas or hip flexor-related groin pain, inguinal-related groin pain, pubic-related groin pain, hip, and by hip they mean intra-articular hip-related groin pain, and then, of course, the ever-present other. And since that time, the data and the literature does suggest that we do find good intra-observer and inter-observer agreement and reliability in using clinical schema like this when it comes to addressing groin pain in athletes. And additionally, there was good correlation between this clinical schema with other findings and other diagnostic modalities such as MRI. However, more recent studies such as that in 2023 does present an interesting wrinkle, and that is there was lower agreement rates when athletes were classified with multiple clinical entities, so caution is advised there. So what's the best management strategy when it comes to athletes with groin pain? Certainly it makes sense to take into account many different factors in order to find the optimal treatment modality for a particular patient. Certainly return to sport timeline and level of participation. The personal patient and athlete goals and preferences should be taken into account in that shared decision-making model. It follows that targeting a specific cause or a pathoetiologic entity makes sense when it comes to optimizing our outcomes. However, this isn't always possible. In the absence of being able to diagnose a particular etiologic entity as the cause of the patient's symptoms, generalizing management to the most likely entity seems reasonable. So what are the most likely entities that we might encounter? So Holmich et al. In 2007 looked at the categories that were eventually put into the Doha Consensus Statement and found that by far and away, adductor-related groin pain was the most common category encountered, followed by iliopsoas-related and inguinal-related groin pain making up number 2 and number 3. This was also corroborated by Taylor et al. In 2018. So one would surmise, and I would propose that the most common diagnoses that we encounter are very amenable to non-operative treatment. Looking at adductor-related groin pain, the literature out there, the classic literature, the early studies looking at adductor-related groin pain favors an active rehabilitative approach over a passive treatment approach when it comes to athletes with chronic groin injuries presented as adductor-related groin pain. Adam Ware et al. In 2011 wanted to explore ways to perhaps move up the timeline to return to play, and he found that instituting a return to running program did shorten the time to return to play by an average of 4.5 weeks. More recent studies and systematic reviews summarized here in 2022 and 2023 continue to support active rehabilitation strategies as a favorable first-line treatment for adductor-related groin pain in athletes, a promising significant reduction in pain, improved function, and a faster return to play. And then in 2021, a systematic review looked at non-operative adjuncts to rehab for adductor-related groin pain, showing good evidence to support compression therapy, manual therapy, and prolotherapy injections as an adjunct to rehab in treating adductor-related groin pain. However, the authors did caution that the data is still limited and more further study is warranted. Looking at iliopsoas-related groin pain, rehabilitation remains the mainstay of treatment here, with most cases of iliopsoas-related pain responding to conservative treatment. However, that doesn't always happen, and recalcitrant cases may respond to corticosteroid injections. Case in point, the study published by Garala et al. In 2014 looking at psoas tendinopathy, and the authors concluding that ultrasound-guided steroid injections may provide long-term pain relief in patients with iliopsoas-related pain. Now, inguinal-related groin pain is a category with its own fairly large differential diagnosis, and that does include hernia and pre-hernia conditions, but it also includes local neuralgias, such as those encountered and involving the ilioinguinal, iliohypogastric, and genitofemoral nerves. And clinical experience has suggested that ultrasound-guided injections may be fairly helpful in providing long-term pain relief here. And local enthesopathies also can present as inguinal-related groin pain. Case in point, this study presented by Ashby et al. In 1994 looked at inguinal ligament enthesopathies presenting as inguinal-related groin pain and found that the addition of corticosteroid injections resulted in better outcomes than in cases that did not receive the injection. And then Schulten et al. And St. Ange et al. In 2015 presented clinical experience that supported the use of ultrasound-guided interventions such as needle tenotomy and PRP injections in improving pain and returning athletes to sports participation. And more recently, Ozgon et al. In 2020 looked at dextrose prolotherapy versus PRP injections in the treatment of long-standing groin pain, and concluded that both dextrose prolotherapy and PRP, followed by rehab, can improve function. So, and then when looking at the top surgical causes, Holmich et al. Did find in 2016 that the number one surgical cause of chronic groin pain was FAI, or femoroacetabular impingement. And I would propose that this cause is also fairly amenable to non-operative treatment. Clinical experience such as that published by Pennock et al. In 2018 and Ebert and colleagues in 2023 do support the combination of rehab approaches and guided intra-articular steroid injections in the hip as providing favorable outcomes, with numbers ranging between 68 to 82% of patients being satisfied enough to avoid surgery. So my take-home points for my portion here, that recalcitrant groin pain is confusing sometimes, but thankfully we do have a paradigm and a framework through which we can apply our clinical judgment through. The Doha Consensus Statement remains the best framework today, and I would propose that the most common causes of athletic pubalgia and the top common surgical cause in athletic pubalgia that we will encounter as sports medicine docs are very amenable to non-operative treatment. So with that, I would like to hand things over to my colleague, Dr. Lamond.
Thank you so much. I really appreciate it. And thank you to Matt and Will and Gary for having me here today. This is a topic that is near and dear to my heart, so I really appreciate the forum. This is a fantastic conference. I do have one disclosure not related to the work I do with sports hernias. I'm just going to use that term as it is. But I would like to tell everyone that I used to be on the debate team when I was in high school. So we had 3 major rules. One is to use big debate words like resolved. So this is our topic. Surgical therapy can be superior to non-surgical therapy in the management of athletic pubalgia. So that was the first rule. The second is to be an expert and very confident in your topic. And since I do this for a living, I hope that I can show some nice operative pictures that will prove my side. And third, when in doubt, belittle and make fun of your opponent, which actually won't work today because it turns out Dr. Ho is one of the most fantastic people on the planet. So I will have failed at that technique. The real question we'll be discussing today is picking the right patient. And Dr. Ho has already described in a fantastic way the difficulty of diagnosing and displaying what this condition is. Now, I have spoken in the surgery forum on this topic many times as well, but our discussions and our debates revolve not around what type of surgery to do, but whether this condition exists at all. And so a lot of my colleagues will make fun of the fact that sports hernias don't even exist, and really what we're doing is rubbing snake oil on it after all. So hopefully by the end of today, we'll all understand a little bit about what is done in the operating room. Again, thank you for displaying already the definitions and diagnostic techniques. I'll talk a little bit about surgery, and then hopefully in the right patient, we can help them along the way. The majority of the patients that come to see me have already been seen by some of you. I would like to think about 90% of folks in the room already agree that this condition exists, and a lot of the patients have already undergone therapies, imaging, physical therapy, sometimes injections as well. But it is important to delineate these patients as opposed to non-athletes. If you open your surgery clinic to a groin pain category, you see a lot of patients, right? So I'll never forget one of the first groin pain patients that came my way. She was an 86-year-old grandmother who had moved a dresser, and lo and behold, she wound up with groin pain. And I thought, this is not what I bargained for. So it's important to really categorize the condition you think you're dealing with. So high-performance athletes, groin pain that is reproduced during activity, alleviated by rest, not cured by long-term rehab, anti-inflammatories, etc. And these are very debilitating injuries. People are sidelined for this. We've already discussed anatomy here, and I will sort of outline as my pictures proceed. History is extremely important, and when I describe these conditions to patients, just like any other entity, we use history, physical exam, and imaging, and history sometimes is the most important. Typically, these injuries develop chronically with sport, not an acute fall, not an acute injury. The athlete doesn't remember a single event, but they continue to have pain with extremes, such as pivoting, kicking, sudden movements, worse with propulsive movements and sit-ups, pain with sneezing, getting in and out of a car. This is what's really affecting them, and pain management and NSAID use isn't necessarily helpful. Physical exam rules out a lot of other injuries. They don't have clicking in their hip. There's not a true hernia. There's not an obvious bulge. They typically have tenderness at the pubic tubercle and pain with flexion and adduction of their lower extremities. Here's essentially a resisted sit-up, and they typically have pain in this area, but not a reproducible hernia. In terms of imaging, imaging is not perfect, specifically in MRIs, given that it's not dynamic. Ultrasounds can be dynamic. It's very important to have an experienced technician. So depending on who performed the ultrasound, it can't always be trusted. So unless Dr. Ho sends me a patient that he's ultrasounded himself, I can't necessarily agree that there isn't a pathology there. MRIs are typically performed, a pelvic MRI with non-contrast, sometimes with specific oblique cuts, not always. You all look at MRIs probably more than I do, but what can be positive in these patients are possible edema in the inguinal canal, micro tears or rectus tendon injuries or adductor micro tears. Floor disruptions would be a positive, relevant finding. Typically, there's not a true hernia there, and we're ruling out other injuries. I don't know about you all, but I often see incidental findings about 70% of the time of a small labral tear that I then have to convince the patient that they don't actually need hip surgery. So it depends on what is really affecting them most. 70 to 80% of the time in these patients, it can actually be normal. I didn't actually put an arrow there because it lights up itself, and this isn't working perfectly, but you can see it lights up the pubic tubercle, osteitis pubis from those mechanisms of adductor and rectus muscles pulling against each other. But essentially, the transversalis fascia, which you all remember from medical school, the deepest layer, external, internal, and then transversalis, that has become weakened in the patients that I see, and this is how I describe it to them. It's almost a pre-hernia pathology. When they are using these muscles in a propulsive method, such as kicking, coughing, they have discomfort because that tissue has weakened and it bounces against the ilioinguinal nerve and sometimes the genital branch of the genitofemoral nerve. So, with a reasonable history, physical exam, and imaging not consistent with other issues, in a patient who's debilitated from this, if they have pain of a 2 out of 10, I wouldn't touch them with a 10-foot pole. And they have also tried failed conservative management, including medications and physical therapy, I would offer them surgery. They need to have realistic expectations, which I think is very important, that they may not feel 100% perfect, but will make them healthy to be back on the field. So Dr. Mushkowick is the plan that I have followed for many years, over a decade now. She was actually part of the Doha Forum and was part of some of the stipulations and definitions that were created. She developed a technique called the minimal repair, which I'll take us through some of the photos. On the right side of the screen for both of the images, this is the medial side. On the left is the lateral side. That structure you see being pulled down by a ribbon is the spermatocord, and beneath you see the weakened tissue that is here. You could argue that this is a true and true hernia, meaning a real hole, but by definition, because some of the muscle fibers remain intact, it's not a true hernia. But so the minimal repair is about a 4-centimeter incision, localized to that injured transversalis, or that weakened tissue. The basis behind her intervention is that it has aggressive recovery, and she wants people competing again, not just jogging on their own, in about 14 days. So here are some operative pictures of my own. You can see that we mirror this technique. We open the transversalis that's weakened. We decompress any nerve injuries or compressions of these nerves, and then the transversalis fascia is reapproximated in multiple layers. I described this to patients that their tissue was weak like a parachute, and we make it tight like a trampoline so that there's less give that causes them discomfort. This was a movie that didn't translate, but I think you can see a little bit of the relationships of how small the incision is related to the spermatocord and the instruments. Her results are pretty surprising. This is old data of hers, but essentially she has about 70% of professional athletes that she sees. At 4 weeks, 80% were pain-free. 14 days, return to sport. All but one said that they would have surgery again, no questions asked. Her study was not randomized, but this is a little bit of her recovery. I mirror this as well. I like patients to be running at 50% speed, 50% distance at about 14 days, which I think a lot of these athletes really do appreciate. A quick study, a few studies that compare surgery and non-operative management by Extran back in 2001. Prospective study, 66 soccer players with groin pain. Again, a little bit of a catch-all phrase, especially back then, surgery versus conservative management. Only the surgical group showed substantial, significant improvement in the long term. A second study, 60 patients with chronic groin pain, likely sports hernia, with prolonged symptoms. This used a laparoscopic approach. I do a lot of laparoscopic surgery. I don't do this type of surgery in this cohort of patients, mostly because their insurance companies won't cover it. I can't offer an inguinal hernia repair with mesh in someone who does not have an inguinal hernia. Besides that fact, I think the recovery is just as great doing the minimal repair. But in the long term, these patients, after 6 months, some of the non-operative group had to switch over to the surgery group so that they could have success. Surgery is superior. The diagnosis can be very complicated. In the right patient with a pre-hernia type of pathology, patients with correct expectations, those with reasonably debilitating pain over about a 4 out of 10 up to a 9 out of 10, we can cure their discomfort. Thanks very much.
Awesome. Thank you guys so much for clarifying a couple of confusing points that I still figured that I need to ask you a few more questions about.
Dr. Ho, obviously you discussed several different diagnoses as part of pelvic pain in athletes. Can you give some sense of the types of injections or certain specific etiologies in which you've seen more success with injections, and potentially what types of injections were included on those?
Absolutely. Thanks for the question. I think it kind of depends. It depends on the goal as well as the timing and what injection you're talking about. I think if we're talking about corticosteroid injections and other pain-relieving injections, they can be particularly useful in helping an athlete stay in season and then addressing their pathology more definitively later if symptoms recur. So as far as what injections can be done, and we mentioned a little bit about corticosteroid injections in and around some of those tendinous enthesopathies. I do also a fair amount of PRP as well. And that's something that we can use, probably not necessarily something in season, but maybe post-season for some of the enthesopathies in the area, and found reasonable success for that, although the evidence specifically for these pathologies in the pelvic and inguinal area is lacking, and we extrapolate quite a bit.
Thanks. Dr. Lamond, in your opinion, should a patient consider PRP versus prolotherapy before referral to surgery, and in those cases where you've had patients that do have a procedure prior to your surgical intervention, are there any impact on outcomes for those patients?
So with regards to any type of conservative therapy, such as PRP injections, et cetera, I'm a big fan of those. It also always depends on where an athlete is in their training. So if they're off-season versus in-season versus headed to a tryout, I think it's all very relevant with regard to what treatment we proceed with. But if they're still able to compete in their mid-season, try anything possible. So if we'll push them through until the end of the season, which I think everyone in the room would sort of understand. So I'm a big fan of encouraging all of the non-operative therapies. The second part of your question I didn't really hear, sorry.
Is there any impact on outcomes for those patients? if they've had
So-
a procedure ahead of time?
I defer that to Gary, but the bottom line is even if there's a 20% success rate for PRP, if that decreases any sort of discomfort that relates to micro tearing of any of the musculature, if that's what causes patients to have pain, then again, I think it's worth proceeding. It's not going to fix the relative pre-hernia defect that's there, but if it pushes people through towards the end of the season, I think it's worth doing.
I agree with Kate on that. I think that there's a lot of modalities we can use that can be a bridge, but I have yet to see an actual change in that incipient bulge on ultrasound following any kind of regenerative treatment. I'll just make another comment. That's one of the reasons why I asked for that clarifying question when I was first asked to talk about sports hernia, was because if we were solely focusing on hernia and pre-hernia conditions, it would be a very short point-counterpoint.
Great. We also have a lot of interest in the minimal repair technique, Dr. Lamond, and the common question that's come up is there a registry of surgeons that use this approach? And if we have a surgeon locally that uses a different approach, is that something we need to look more into or be concerned with?
I think it would be great to have a registry. Honestly, there are a few barriers that are in front of general surgeons, not because the surgery is difficult. It's not. We're in the inguinal canal all the time. It's a very easy surgery to perform. The difficult part is, again, opening your clinic to the basis of groin pain, not knowing what to do with possibly 50 to 80% of those patients that aren't operative candidates. So it's sort of a catch-all situation. And then the reimbursement and effort that it takes to get these people sometimes to the operating room can be a barrier for general surgeons. So unless you're really dedicated to do it, I mean, I write a peer-to-peer every week on patients that we're trying to get to the operating room without using terms like sports hernia, et cetera, because a lot of the insurance companies don't like it. So it's a difficult diagnosis in the general surgery world. So go ahead, let's make a registry of surgeons. Let's do it.
All right, we've got a project. Dr. Ho and Dr. Lamond, any role of pelvic floor therapy for some of these patients? Or any success with that in the past?
That sounds non-operative to me, Gary.
All right, I'll take that. So definitely a role for therapy. I think that, when I take that question, a role for pelvic floor therapy, again, I have to ask a clarifying question. A lot of the therapeutic and rehabilitative approaches that I mentioned when it comes to adductor-related, iliopsoas-related, frequently pelvic floor therapists have an interest in that region and are very familiar with the physical therapy of those conditions. So yeah, I think there's a role, along the same lines as physical therapy in general and rehab for these conditions that I talked about. However, if you're talking about specifically rehabilitation of the pelvic floor, I think, treating the problem. I often routinely in my ultrasounds, when I assess, I do a quick look, a screen look at the pelvic floor. If there is pelvic floor dysfunction, then I definitely think rehabilitative approaches directed at the pelvic floor can be helpful. Specific for the neuralgias that I talked about, if there's no pelvic floor dysfunction and there's no pain being generated from there, I don't think there's a role. But again, it just comes down to treating the patient and not necessarily the picture, as I often say to my fellows and residents that I've worked with in the past. So the answer is yes, and just get the patient what they need.
And I think it's very clear that almost nothing burns any surgical bridges at the end of the day, so it's always worth a shot. And I defer to my orthopedic colleagues, but any sort of muscle strengthening you can do before an operation can certainly help with rehab.
A lot of them will do okay until they take up pickleball, and then that's it.
Great. We'll end with that. Thank you so much for your attention today. Thanks for a wonderful panel.
Thank you for coming. Enjoyed it.
That was fun.
Dragged it. Fun.